Hi, thanks, Katrina. So as Katrina says, I'm Scott Parker. I am the Director of Healthcare Intelligence Division at Vital Hub UK, and I originated in Beautiful Information, which became part of Vital Hub last year. And we've developed some patient tracking solutions, list solutions, which started more than 10 years ago. And we have been working very closely with Ashford and St Peters for the last 4 years to kind of introduce the same solutions there. So Anne, as you saw, was Deputy Chief Operating Officer at Ashford and St Peters, which is quite a large acute provider in Surrey, with population observing over 410,000 people. I'm sure Anne can tell you more. And over the last few years, we've developed solutions to support the emergency department, inpatients, and cancer. When we originally built the patient tracking solutions, they all stemmed from a requirement in East Kent hospitals, where they had a real challenge that the loads of holes left by their existing PAS systems and other administrative and clinical systems, that there was really important operational information and that needed to be logged and shared as they manage patients flow through the hospital. And they were relying, there was an over-reliance on Excel spreadsheets, clunky Excel spreadsheets, or writing things on walls or bits of papers as they try to get the patients into the most appropriate setting. The EPR and PAS providers and other administrative systems were really slow to respond to any potential changes. Anytime a new field needed to be added, or a new way of doing things, workflow changed, or new sites were added, they were either slow or very expensive to try and change that. And they're often very much focused on their own system rather than necessarily bringing lots of systems all together into a single view. So that's kind of where we started developing them, and that was kind of where we've seen massive benefits down in Kent, which we try to deliver in Surrey. So Anne, did you have similar challenges, and why did you see the need for the PTL solution?
So I think the original conversation was born out of a cancer PTL need, just because what was being used locally was Somerset, and there was a lack of visibility there. But when I went to see the methodology or the operational PTLs working in East Kent, I then began to think, actually, we can apply them to other places. So as we have grown in our use and our knowledge of the PTLs, we've shared that from ED, cancer, and the inpatient PTL. And for me, the critical point of all of this was to ensure that I had one single source of the truth. And what I mean by that is the PTLs give us a patient information on one line, so you can see the whole story of the patient in one line. So we've now moved to a clinical system called Cerna, which I'm sure many people have, which is great for capturing the clinical information, but it's that crucial tracking information that means we can manage the ED, we can manage the cancer PTL, and also as wards, we now have an inpatient PTL, and each ward has their individual PTL, and that allows me to have that visible story, real time, updated on board rounds for each patient. It allows us to do the forensics at the back end, who's going home today, who's going home tomorrow, do the planning. There's one story, all of the teams input into that one story. So it allows that drill down, and it's accessible to the operational teams. So we're talking about the same patient. We've got the same information. It's not something that is carried around on pieces of paper that we discuss often. Previously, we were discussing different patients at CAT meetings based on what was captured locally on different systems. So that was my primary motivation for getting the PTLs up and running.
Okay, maybe we can go in and have a look at some of the PTLs that you've got. So if you, I'll share my screen and show the demo site, which is obviously going to be using non-patient identifiable data, but the functionality largely mirrors what we've got at Ashford and St Peters. So if we can kind of go through them one by one, you kind of show how you use them. So
okay. So the one that's used most, I think, is the inpatient PTL. Well, the cancer PTL and the inpatient PTL are probably the most functional ones. ED was really, really good up until we had Cerna, but there's some data capture issues that we haven't been able to capture in a way from Cerna that will then feed the PTL. So it's missing some information in comparison to how it used to be. The key point and the key benefit of the emergency care PTL is also the COVID status. So that pulls from the ICE system, the pathology system, and it'll pull from the CRIS system. So we can get that story together in one place.
Okay, well, I'll start off with the ED PTL then.
Okay.
Hopefully you're seeing my screen. So this is the kind of the front
end. That's the overview, yeah.
The overview. And if we go down into the patients in department.
So the primary ask around this PTL was we'd purchased Cerna, and we had clinicians also wanting Symphony, which was something that we absolutely couldn't have given the trajectory we were on with Cerna. So the PTL was developed using the old system. It has transitioned to Cerna. And what you can see there is a hospital number, patient information. It's all red now, but it is RAG rated depending on how long somebody has been in the department. This is the demo model. So you're not necessarily seeing that functionality, but I would expect to look at it and see some yellows and greens and other patients towards the end of, or towards the start of their pathway. And what I can see looking across that is their COVID status. Generally speaking, in that column, you get a red positive or a green negative. So we could see quite quickly whether a patient can be moved into which wards in the hospital if they got a DTA. We can see what the presenting condition is, triage status, sex, age, which area they are in, and which team they're under. The imaging column also on the real version allows more functionality there because we can see how many images have been requested and where they are in terms of whether they've been completed, whether the report is ready, and that's RAG rated also. And then the rest of the PTL is built on the urgent care professional standards that we all know and love, and there are visual prompts there that are RAG rated also. The bed functionality at the end, well, a couple of columns from the right, is whether a bed has been requested. So it'll be red. If it's been allocated, it's amber, and if it's green, the patient is on their way to that bed, away from the department. There's also the option of putting a little bit of a narrative in there and an ED plan. What I expect to see there from my clinicians is whether the patient can go to SDEC, whether they need to come in to an inpatient bed, or whether they can come to CAU. And our CNSP team, so the site team, in hours and out of hours, will use that to pull patients into the appropriate places, either between ED and CAU or into the inpatient beds. I think that's all I can, quick summary of the ED PTL. I don't know if you want to have a conversation about them first of all, or just go through them, and then we can talk about them later.
Yeah, if we just go through them one by one, and then we can come back to them if need be. So shall we go to cancer PTL now? Because I think this was kind of where we started initially. Again, this data is dummy data.
This was the first attempt, and I think what I can say is this is one, I think, of our loveliest PTLs, just because of the functionality that's in here, the level of detail that's in here, but also it's to do with the level of input the team have had in terms of designing it, and that design work continues. We're constantly improving it and constantly reviewing what we need to do. So again, what you can't see here is there's a front screen that shows you in a breakdown of where they go, 14 days, 28 days, and subsequent days pathway. Total number of patients on the PTL, and who is green, amber, and that's kind of a red color, depending on where they are on their pathway. And you can click into each of those areas if you want to review. But generally speaking, what the teams do is they have do you want to just take it to a tumor specific one? Any of the tumor sites, I don't mind. So the tumor site will be looking and managing their PTL across the week and throughout the days. And what we have there is the key milestones on the pathway, so that the patients can be tracked against time intervals, and how quickly we expect a diagnostic to come back, quickly we expect to get to an MDT discussion, etc., etc. And all of that is RAG rated, and it allows us to do prompts. So the PTL is designed to prompt those involved to follow up an action. You can put in a follow-up action and you can put in a timeline. All of that functionality isn't available to us on Somerset. And we can see what the next step in the pathway is. So it's constantly a push in the pathway.
Great, thanks.
And there's an ability also to write tasks in. So you can add tasks, you can add comments to enable people to follow those up, or as reminders. We do a clinical PTL with the local team, and then there's a divisional PTL at various stages in the week, and then there's a final trust PTL on Thursday where we do all the follow-up actions and we check that people are meeting the right milestones. One of the things that we haven't, I don't know if you've got a copy of it, Scott, is we then have an overview. So we pull all this information into a cancer 2-week wait daily information. We call it our cancer tree. But what I can then do is each of the divisions, the ADO for each of the divisions will look at that on a daily basis and use that to prompt their teams and to target effort.
No, I'm afraid I haven't got that.
Okay, sorry, we'll remember that for next time.
Okay, thanks. So we'll go on to the inpatient PTL, which has initially as a kind of a view of all of the wards in the hospital. And I think we have got some more fake data in a couple of these wards, in cherry and chestnut wards. So
the key thing around the inpatient PTL was the huge frustration about the lack of connection of stories around the patient between therapists, medical, nursing, discharge. And it was only on having a meeting with all of those stakeholders that people were saying, actually, there's no place that we can all go to for this piece of information. And then my ask to them was, okay, are you prepared to manage each ward like a PTL? And if so, we can use a PTL system. So the teams agreed that they would, which is when we went back to Beautiful Information and said, can we have an inpatient PTL, please? And we want this to work at each ward level, so that it is that single source of truth. It is updated. It's the nurse in charge's responsibility to make sure that somebody updates it at the board round. It also provides 4 different views depending on where you are in the system. So I've got a discharge. Oh, it's 5 now because it's got adult social care. I've got that down separately, actually. So there's a ward view, discharge view, medically fit for discharge, which is one of the things that our divisional teams use most of. There's a general view, and there's a acute social services, or the adult social services view, which colleagues in adult social services, they don't have access to all of the information, but they have enough to allow them to do their part in the pathway. And one of the things in our future steps is how can we provide more of a pipeline for adult social services? I think I can say a little bit more about that shortly. But we've also got e-forms in there. So not all of the information that we want is available to capture on Cerner or the information system beforehand. So the PTLs have a functionality in there called e-forms, which is basically we've created them as a series of drop-down boxes and tick boxes to allow people to tell the patient's story so that we can capture that. That is something that is really, really helpful for our discharge team. It drives our non-medically fit for discharge meetings daily, and it drives our ward discussions, board discussions daily, and then feeds into the number of definite discharges and potential discharges. So is able to provide that overview at times of CAF meetings in terms of what flow we're expecting across the hospital. So we got, you can just see the e-form there. There's ward actions, there's escalations if we need to make them. There's right to reside actions. Therapies have a piece. D2A, has that happened? Who's doing it? What it's like? And then discharge planning. So all of that story is in there. And I think that is, for me, is one of the key enablers to managing discharge across the hospital. And as I said, the piece of work that we're now working on is being able to, at the end of each day, be able to provide a breakdown to adult social care to say, in the next 7 days, we will need X number of packages. We're going to break that down into P1, 2, and 3, and we're going to give them information about the patient's age, obviously their name and hospital number, but as well as that, where they live, which allows colleagues in adult social care to then go to East Brokerage and start having those conversations about the packages of care that we need, and hopefully planning ahead, not waiting until the patient is medically fit for discharge. So I think that is everything we covered on the inpatient PTL.
And this isn't just information from Cerner, is it? And there's the manual input, but we're sort of pulling together data from other systems as well, like your obs system.
Yeah, and CRIS, the radiology system, and ICE, the pathology system.
Yeah.
So it's got information from all of those, and very cleverly in cancer, we've also worked with some rapid process automation to pull the data from the systems using the PTL in order to start prepping the MDT list. So that's been a labor of love as well. But in essence, it's it's reducing the amount of time that people spend chasing things and searching things out.
Okay. So what happens when things change? There's obviously been big change.
Yeah.
Over the course of the last few years, and with COVID and Cerner, and obviously ever-changing reporting requirements. So how has that been dealt with?
So I think the biggest challenge for us, because the data's here in terms of reporting, and it goes through a data warehouse, and we can craft the reports that we need, either sourcing the data from Cerner or a mixture of the two. So that was easy enough. The biggest challenge we had was that transition to Cerner, and as I said at the beginning of the presentation, we're not back to where I'd like to be for ED yet, because Cerner doesn't capture some of the data points. So we're going to have a look at where we can get them from, and it's using so that transition was really difficult for us. I think it took us a lot longer than we thought it was going to. There's some very helpful bits, but there are some very challenging bits in that. None of it is insurmountable, but it all takes time. So we had a very pressurized internal IT team with the implementation of Cerner and information team. So just getting things on the priority list was really, really hard. We're in a better place now, but we're bringing these things all together, the Cerner stabilization, and the other work that needs to be done is coming together in one place. So I think we're now with a manageable work plan for that.
I mean, the whole point of the system that we developed was something as flexible as possible, and therefore that as and when there were changes, if the data was coming from a different source, which has often been the case with the Cerner, so removing things from the e-forms or putting stuff back on there or adding additional fields, I think we've tried to make sure that we've given you that flexibility to whatever happens, whatever new requirement, that we can adapt quite quickly and work with you. We meet regularly to then talk about kind of what's next, what do we need to change, how's this going to be best. So it's always an ever evolving solution, isn't it? It's definitely not off the shelf. So can you talk a bit about that and some of the recent stuff that we've included, for example, like potentially around estimated discharge dates? And
so at the moment we record EDDs in different places. They go into Cerner, but from the point of view of the beautiful information PTLs, what my medical director was very keen to do is that has been based on an algorithm, so that it's automatically generated, and therefore we can hold people to account to something that is has more science to it than an arbitrary EDD that teams will pull together. And that's part of what drives our discharge planning across the site. I think the other area, as people have worked with these PTLs and come to know how to use them and feel familiar with them, there's often asks from the team to develop new PTLs and to increase the functionality. I think one of the ones that I've most recently that I think is going to add the most value is some surveillance PTLs that we're working to put alongside the cancer PTL, so that people who've been treated for cancer but need some surveillance pathway can also be managed on a specific PTL that will prompt things like scan appointments, etc., etc., and give the clinical teams the assurance that those patients will be managed appropriately and they won't be lost.
So what are you getting now that you perhaps didn't before? What are the kind of key benefits that you're seeing?
So the benefits for me are the time saving. The time saving just across the day, because we're not having multiple conversations trying to unpick what's happening with the pathway. The it allows us a laser focus on discharge. And I think it also allows us to have a real grip on cancer pathways and what we need to do there. So those are the areas that I think we've had the most benefit, and just being able to track patients through. We have an initiative called Criteria to Admit, and obviously criteria to reside in the hospital, and it allows us to hold that, and we can look at that across the PTLs at CAT meetings and know whether we're achieving what we set out at the beginning of the day or a couple of hours ago, and follow that up.
Great. And you talked a bit about kind of what's next, and I know you've got a long wish list.
Obviously, yeah, always.
We'll see how we tackle, but kind of, you know, where do you see the future? What are the things you really love to see, apart from the kind of the adult social care stuff?
So I think the adult social care stuff would be a real benefit, just allowing us to expedite some of those discharges. So I think that the benefit of that shouldn't be underestimated. I think we've got more to go to manage the efficiencies of our discharges internally. And I think playing that information back to teams locally and focusing on the EDDs is going to be more beneficial internally. And I think on the back of some of this, what we've been able to do is have that focus, but we've closed escalation beds when I think lots of organisations are actually opening escalation beds. It's allowing us to consolidate on towards the groups of patients that we need on wards. So if a patient is medically fit for discharge and we can't get them out within the day, we'll put them on a medically fit for discharge ward. And then we have a call with Northwest Surrey partners to look at patients who are medically fit for discharge every morning. We go through the PTLs, and we use that and the action plan in there to hold people to account. So what you will see at Ashford and St. Peter's is our length of stay for greater than 7, greater than 14 and greater than 21 days is lower than other organisations. Certainly across our Surrey Heartlands.
Yeah, well, thanks very much for that. So I think we're about ready for questions if anyone wants to. Katrina, do you want to?
Brilliant. Yeah, thank you both very much. Really insightful there. And I have got a question in from Nata in West Hertfordshire. So she's asking, who owns the data in the data warehouse?
It's our data warehouse. It's our data. And what Beautiful Information do for us, or Vital Hubs do for us, is they help us choreograph it into a way that we can manage it, and we have that visibility that I talked about earlier. Definitely our data.
Yeah, it stays that way. I've had a couple of questions come through to me directly. I've written them down. So the first one is, who typically has access to these patient tracking lists and who uses them?
Okay, so the people who have access are the people that are connected to that pathway. So obviously in cancer, it is the clinical teams that manage cancer, and it is the central cancer team. And the management teams associated in the same way that if you have probably an Excel PTL somewhere, it'll be the same thing. For the wards, it's the ward-based teams that have access, my site team, the divisions that are managing those wards, and obviously myself and my exec colleagues.
Another one, which is a bit of an unusual, but do you get much pushback, or have you had much pushback? And what does that look like when you do get pushback? How do you manage it, I guess?
So the pushback has really been about different systems and people who are under pressure trying to manage different systems. There was more of that pre the Cerna implementation, just because we had more systems then. So Cerna has reduced the number of systems, and what we do is we're very clear about what the function of each system is. the function of Cerna is to capture all of the clinical information, and any information that goes into Cerna and is captured that can be fed into the PTLs that we need is fed in. So there's no duplication of the entry of the same information. And then on the PTLs, there's an opportunity to capture other information that is not captured in Cerna. And the PTLs are very much about the tracking of the patient, about them getting through the cancer pathway, getting the patient home, getting them out of ED, getting them to discharge, rather than capturing clinical information. So they have different uses. And I think when we describe that to teams and we sit down and we have those conversations, it is the why is understood. So we get a little bit more buy-in really at that stage.
Always positive. Thank you for that. If there's any more questions, obviously we'll just give it another minute or so and see if anybody else would like to ask anything. Please do just pop your questions in the chat, or if you'd like to speak to Anne or Scott directly, just raise your hand and we will let you speak by turning on your mic. While we wait, is there anything that either of you wish to add to that? We'll finish up otherwise, I think.
Well, one of the things that we have talked about, not just in Ashford and St Peters and in Surrey, but in other areas, was not just the view within the hospital, and to try and kind of the challenge of kind of sharing information as patients are shared across a healthcare system. So in some places we have an acute and a community provider working closely together with a shared view of patients, so the acute people can see the community bed and vice versa, and you have an IDT team to help manage these patients. And clearly that's becoming there's an increasing need for that, but there's obviously some real challenges about that. Never mind the different systems, but and the governance around managing those patients. But I don't know if you had any thoughts about that, Anne. We haven't really talked about that very much in Surrey, but I know there is interest about potentially doing a shared cancer PTL, which we have done in Kent and Medway, but it's not so straightforward in Surrey and Sussex because of the variety of setups. But do you see that kind of as a need, that linking with the community?
Yeah, I think it would be a really interesting functionality to have in there, and it would certainly help with the management of patients across the unit in a cancer centre. I know our Cancer Alliance are really interested in our PTL, and they've had conversations with yourselves about how easy it would be to scale up. And I guess the other opportunity that we see coming along is the link with Shrewd, and how that will allow us to have a picture across the Surrey Heartlands in terms of capacity and demand and front door, and really will help that mutual aid piece a little bit more and planning.
Yeah, maybe it's worth me just kind of explaining what Shrewd is to anyone that doesn't know. It's another VitalHub product, but it's so with the ICB, and the idea is it provides a system overview across multiple providers, including primary care, mental health, etc., all coming into kind of a system overview dashboard to kind of identify where the pressures are at any given moment, with live ED data from all of the providers and ambulance data, etc. And what we hope to do, and what we ultimately will hope to do in Ashford and St Peters, is provide a link from that system overview dashboard down into the patient level, so that if you can see on Shrewd that there are 29 patients in department, that those people that have the necessary access to go down to that patient level information will be able to drill down, and that could work across many different indicators. So within this control center, there is potential for people to go down and not just see the headline figures, but to be able to drill down into those patient tracking lists. So yeah, that's we're kind of just starting that process now. So that's really exciting.
Indeed, exciting stuff indeed.
Mm.
Well, thank you both so much. I think we'll leave it there. I'm about to give everybody about 1 minute or maybe just less than that. Thank you both so much, Anne. We know you're exceptionally busy. So we really do appreciate you taking the time to share your learned experiences. And just again to remind everybody joining that we will be sending out the recording of this session to you a little bit later. But yeah, thank you both very much.
Okay, thank you.